Good afternoon, everyone. So thank you to Georgina and the team at Experience-Led Care for inviting myself and Karen, who both have a long history of undertaking group clinics and developing group clinics in partnership with patient families and healthcare professionals. So we're going to split our presentation in two. So I'm going to give you a bit of a whistle-stop tour on my professional and personal journey into undertaking group clinics. And then Karen is going to talk about the art of the possible for community nurses. Next slide, please. So I'm a general practice nurse by a background of 25 years. I still practice 1 day a week, and I'm the primary care nurse lead at NHS England. I started my journey into the world of group clinics back in 2014, and it was with a gentleman called Rob, and I believe he's one of the GPs that set up the British Society of Lifestyle Medicine. And I then met the wonderful Georgina when I was working at Greater Manchester Health and Social Care Partnership. And we started undertaking the model, and we were so surprised with the results, the impact and the outcome, that we wrote about it. So there's 3 people there in that particular paper from 2018. Myself as a general practice nurse, there's a consultant rheumatologist, and there's a pharmacist there. So people talk about integrated care. We definitely had it tailored back in 2018. And as you can see, we know from quite an extensive decade of evidence that this does impact positively across long-term conditions and some aspects of public health and life. Next slide, please. So yes, in my own practice, so I came from a long clinical journey. I worked in Greater Manchester for nearly 18 years as a full-time general practice nurse. And I actually took over the surgery that Harold Shipman had been at. So you can imagine the trust that we had to build with our families and communities, because trust had been destroyed. And one of the best ways that we achieved that was by connecting with our communities. That was really, really important. And looking at the levels of care that we required in our communities. And as we all know in healthcare, time is one of the most important currencies, isn't it? And in general practice, our nurses are delivering 84 million consultations every year. That is huge. But what are the quality of those consultations? And do our workforce feel that they have the time and the headspace? And do our patients, more importantly, feel that they have the time and the headspace to actually talk about what matters to them? So back in the early 2000s, I did something that was considered at the time quite brave. I put a sign up at the local community centre with consent from the CCG at the time to say smokers welcome. It wasn't appreciated by public health, but it did the trick to get the community into that particular space. And for me, what I learned with working with groups is it is reducing health inequalities in the first instance has to be about restoring those relationships. And I think that strikes to the heart of what we actually want to achieve in terms of continuity of care in general practice. Next slide, please. So Karen formerly was the primary care nursing lead at NHS England and has undertaken a tremendous amount of work with both primary and community nurses with something called the 10-point plan, which finished in 2020. And I was one of those nurses in Greater Manchester. I was one of 700 GP practices, in effect, in the Northwest that got involved with Georgina, Karen and the national team to look at how we can create that all-important currency of time and capacity. And you can see here, you know, that we were able to do that. And here are some of the outcomes from the 10-point plan, which have been published in a Health Education England paper. So we knew, for example, that in diabetes, it's one of the strongest areas and it has a good And we know that we're likely to reduce DNAs by at least 49% and cough adherence up by 38%. We saw in our Health Education England report from the Northwest improved staff resilience and well-being because it really boosted the whole team's morale. And nurses and GPs and allied healthcare professionals were able to learn from each other and really do some deep listening. Moving forward, we think that group clinics have a significant place in primary care team cohesion, because some primary care networks are doing some fantastic work and others have still got to come together with some primary aims and values and goals. And we know ultimately that the work that we have achieved has improved patient knowledge and supports access and continuity. Next slide, please. So if you would like a copy of this NHS England system briefing, Georgina touched upon some of the policy drivers around the long-term plan, working with people and communities, and the recovery and access strategies. So this is a briefing put together by our nursing director and the primary care team in 2023. And this gives you, certainly for ICBs and system leaders, all the evidence that you need if you want to have that critical conversation with your GPs, with your PCNs around adaptation and developing this model. Next slide, please. So just to pick out some of the key themes really within that briefing document. So type 2 diabetes as an example. So there's a robust evidence base, including several systematic reviews and randomised controlled trials.
Take that off. Do you need to hear? I want to hear what she's saying.
Oh, sorry.
I can
compared to control. That's all right.
Louis, I'll just see if I can mute that person, Louise, for you.
All right.
Just carry on.
Yeah, so what we found within the 10-year evidence is that group clinics for individuals with type 2 diabetes have a greater positive impact on a range of measures when compared to the traditional one-to-one face-to-face appointment. So that's really significant clinically, particularly with HbA1c, blood pressure, cardiometabolic disease. And we know that particularly for preventative care, deprived communities and underserved communities. And as I say, that smoking cessation group was a classic example where there was still stigma, shame, mental health issues and embarrassment attached to actually going to see, for example, a smoking cessation advisor on a one-to-one, and we were able to create an atmosphere of trust within that community. We know that it improves patients' knowledge of diabetes and results in better patient-initiated driven change. And again, we can see and we can capture a reduction in A&E visits amongst the most vulnerable people living with diabetes. Next slide, please. I don't know if anybody on the call is part of or has heard of the CARE programme. So the CARE programme stands for Connected, Authentic, Resilient and Empowered, and was commissioned by NHS England 3 years ago now, and it's a fully funded quality improvement and leadership and coaching and development course, and it's open to all practice nurses, GPs and allied healthcare professionals. So this is a lovely example of the work of an advanced nurse practitioner that came from my patch called Aisha Badat. And she was able to capture and articulate the impact and the value. And she only worked with 4 patients at her clinic, really taking time to talk about behaviour change, diet, lifestyle, motivational interviewing she was able to include in this group clinic. And you can see, based on the results, 28% decrease in average HbA1c, 4% decrease in BMI, and a 1% decrease in average blood pressure. So these are phenomenal biometric outcomes. You know, we're impacting here on the next potential heart attack and stroke, aren't we? So really, really significant. Next slide, please. Importantly, for patients and the workforce, in a very time pressurized consultation, even on a one-to-one, you are able to use this, and this comes from the National Association of Primary Care. So anybody on the call can use this. We need to capture how activated and how confident our patients are in managing their own health and well-being, because they live with that long-term condition 365 days of the year, not us. And there's a SNOMED code that's linked to your EMIS and your System 1. And the question you ask is, how confident are you to manage your own health and well-being? 1 is not able and 4 is very able. And you will see, after introducing group clinics, even within a 3 and a 6 month period, a 1.8% rise in activation is linked to a reduction of 67 general practitioner appointments per patient per year. Next slide, please. And as Georgina articulated, there are massive benefits for the nursing workforce. Because we know some of the quality outcome framework pieces within general practice can be very repetitive and very tick box protocol driven. What group clinics do is they restore the joy to clinical practice and provide the opportunity to move away from lone working, that GP or that nurse behind closed doors syndrome. The work that's been happening with across Wales and with the government in Wales has shown that it creates social capital. So Marion Lynch is a fantastic nursing professor who has been leading some of that work around sustainable personalisation in group clinics in Wales. We know that the additional role practitioners have been able to have supervisions and support within that group clinic scenario. And non-clinical staff, so our healthcare assistants and our support staff, have been developing confidence and new skills, looking at empathy, relationships, and good team working. Next slide, please. And then, for me, bringing it right up to date, there is a social model of care that is important for wider PCN's population, health and communities. So I've been doing a bit of work recently around carers, unpaid carers, and linking that to specific long-term conditions that might impact upon their life and well-being. So the pictures you see here are myself with Trevor Clower, who's one of our NHS England peer leaders, and we partnered with Yorkshire Tea, and we set up 3 carers roadshows across Yorkshire, Sheffield, Leeds and Barnsley. And we wanted to create within those roadshows time and headspace for some group clinics. So we did a lot of prevention work around health checks, around cancer, early cancer diagnostics, cancer as a long-term condition, around screening, around diabetes, and bite-sized bits of advice, really. Next slide, please. And the reason we did this is because we've got an absolutely critical scenario with our carers across England. So, you know, £445 million to the economy in England and Wales every day. You know, the value of unpaid care is equivalent to a second NHS in England and Wales. And we cannot expect our carers to shoulder the burden. So how can we, as registered nurses, as allied healthcare professionals, support our carers? And one of the ways that we can do this is actually meet people where they're at in their community, in their library, in their marketplace. And we brought the care to them. Next slide, please. So yes, just one example of a social model where you can create group clinics. You can still have that biometric conversation, but within a social environment. So some of the outcome from the 3 roadshows last year, In 3 half days, 3 hours, we saw 2,310 carers and families, and we supported them with their health and care needs, whether it was signposting them to financial support or whether it was giving them advice around hypertension and parameters. And you'll see there at the bottom of the graph, the referral rate back into general practice or to wider community services was very low, because we had highly skilled nurses assessing and treating there on the day. Next slide, please. We also got the carers. We had a small sample of 50 carers across the 3 conurbations to feedback. Was this a good use of our time as clinicians, as allied healthcare professional? Yes, it was amazing, and we feel valued. We feel that you've seen us as a vulnerable group. Next slide, please. And what about the staff? What about the workforce? So here we've got examples of the narrative from different nurses across those ICSs. So from student nurses who've managed to have a placement as part of that group clinic scenario, from parish nurses who deal with holistic spiritual care for all religions and none, general practice nurses and our district nurses teams who have vast amount of caseloads but don't always have the time to spend with carers. So I think there's important touch points here from a workforce perspective, and we really need to look and develop the evidence base around that. And we are starting a new project called One Devon with Georgina and her team, and we will be evaluating externally the impact of this model on the totality of our workforce. Next slide, please. Over to Karen.
Thanks, Louise. Good afternoon, everybody. My name's Karen Story, and I'm Community Nursing Lead at NHS England, working with Louise in the team. And lovely to meet you all. I'm here really just to give my support to group clinics, group consultations, because as Louise has really articulated really well, there's a real compelling reason for having group consultations in your practice. You can see what it's able to achieve and the outcome measures for patients. And I've been working with Georgina for many years to implement group consultations within primary care. And as a result of that work, I think Georgina was actually won an HSJ award at the time for the work that she did there. So I know that it really works. And I'd like us to consider then how we might be able to extend group clinics into community nursing, where I'm working now in this space. So we know that from having an initial conversation with some of our community nursing fellows that worked with us at NHS England, we explored with them the possibility of introducing group clinics into community nursing and district nursing, and they were really encouraged by the possibility. They could see that it could have a big impact on chronic disease reviews, that it could really help in terms of wound care by having wound care parties. They could see that it had real possibility around check-ins with patients who are housebound, and that we could do targeted support for specific cohorts. It could help to reduce waiting lists and facilitate group assessments. It could be used within insulin initiations and prehabilitation groups. Family circles could be used within paediatrics, for example. So, you know, the list we thought was endless. And you may have some ideas yourself about how this might be able to benefit your particular area. Could you go on to the next slide, please? So these are our fellows from the regions. You may know some of them. Those of you that are in community nursing, district nursing, you may recognise them, and they would really welcome you getting in touch with them. They're not currently on their fellowship now that's ended, but they're still keen to roll out the concept of group clinics within the area and add support to it. Could we have the next slide, please? So we know that within community and primary care nursing that it touches the lives across many age groups, and I'm sure you'll be able to relate to using clinics across all of these age groups here. You will be able to have thoughts and ideas yourself around how it might be able to be used in your area. Next slide, please. And whilst community nursing has had a group of fellows currently working with them, they had a previous group of nurses who came to work from the community as fellows within NHS England, and they developed a career pathway that's in the form of a tube map, which actually just really demonstrates the extent of the amount of roles within community nursing. And community nursing in this case is thought of in its broadest sense, so general practice nursing, primary care nursing, school nursing, health visitors, district nurses, and many others are included in this community nursing pathway. And so in thinking about in your area of work, how could group clinics, how could group consultations lend itself to your area of work? Because we believe that it is possible to do that. Next slide, please. So I think the message, because Louise has summed up everything and given such a compelling view of group clinics, I probably haven't got any more to say other than, doing things together. That's what we want to be able to do with our patients, with clinicians, with primary care nurses, community nurses, working together across the system. We'll hope you'll be able to embrace this and give it a go. And I think I'm handing over back to Georgina now.
That's brilliant. Thank you so much, ladies. And I think, it's really interesting when we think about how the sort of dynamics of the conversations that we have with our patients are now in a one-to-one, and the idea of being together in a circle to heal ourselves. It really is that last quote that you've put up there really does resonate, doesn't it? It's very exciting to think about how we can really empower our patients by working in a group way. I think the other thing is that I think it's right that we haven't, but I think the other thing that is really important to highlight is the potential time efficiencies for our nurses of working this way. So remember what I said about the nurse who found that 50% of her time was freed up by doing her diabetes reviews in groups rather than one-to-ones, and how she was able to then pursue the things that give her lots of joy in her practice, that she was, able to fit in because she wasn't spending her whole time doing diabetes reviews. And I must admit, if I haven't been a nurse myself, but if I put myself in the shoes of a nurse sitting in a darkened consulting room, repeating yourself, patient after patient, saying the same things, having the same conversation, how much better would it be to be in a room with those patients, whether it's virtual or face to face, and get all that brilliant interaction and that kind of thing. But I'm going to be quiet now because you have the opportunity to ask questions of Louise and of Karen. So if anyone's got any questions they want to ask, you can either unmute or just pop it into the chat. We're not, you haven't put any questions in the chat yet so far, so I think unmuting might be the way to go. So just unmute, ask your question. Let's spend 10 minutes or so talking about this and how the art of the possible. Shirley, you'll get the recording sent to you automatically in an email once it's uploaded to our website. Has anyone got any questions or reflections? It doesn't have to be a question. Are you excited? What are you feeling? You can unmute yourselves, I think.
Yeah, it sounds exciting, very exciting. Yeah. My question would be, is there still training? Because I previously, my manager done the training and some GPs, but I didn't manage to get on the training, some issues, and then I think I couldn't do the dates. So I would probably like further dates of training available.
Okay, so just pop into the chat where you're based, the details of your surgery. If you've been on one of our training programs, the training is on a continuous loop, so we can definitely arrange that for you, no problem. So we just need to check a little bit more. I'm sure we can find a way if you've been trained in the past. Any other thoughts?
Sorry, Julian, I'll take the leap of faith. I don't mind doing that. We've got a group of community diabetes nurses that I think would really benefit from the group insulin start. So to have some information on that, as well as the briefing that everyone's mentioned, would be really, really unique. We've got 4 DSNs currently in post across 51 practices in West Kent that I service manage. So I think having an insight, and I just want to say thank you to Louise and Karen for their real in-depth insight. It was really, really good to hear, and I really would like to obviously try and engage with our community nursing fellow as well, because I think they have some really good insight.
Brilliant. And what I'd suggest is just pop again a little message in the chat and we can pick up. We have done some training with West Kent GP Federation, actually, your long COVID service. But I think, I mean, one of the things that's really exciting is how you could use the group clinic model for specialist nursing to start to integrate with general practice nursing as well and bring the two together. So I think my understanding is that one of the areas where PCNs are struggling a little bit to make progress is to actually drive this integration agenda. And I think working together in group clinics could really help with that. So we've got lots of enthusiasm in Kent, and I know Karen's just pop your email in the chat. You could become a little bit of a test site for that, I think, perhaps, because we have got some funded training there as well. And I know your ICB is really interested. So let's pick that up after the session. Anyone else? I see a few other people popping their emails in the chat. So that's Shirley, yeah, Glebe. I'm pretty certain Glebe might be on one of our programs, but I spend a long time after these sessions going like some kind of surgeon through the chat and writing down everything. And I promise you that if you post in the chat, I will follow you up for sure. It might take me a little while, but I definitely will. Any other thoughts, reflections, questions, ideas that you'd like to bring up now? This is a really lovely time for you to interact.
I'm quite interested in it. Don't know. Can you hear me?
Yeah, we can, Lynn.
So my thought is how you do your group clinic, but then do you get so much time to do your documentation afterwards for each patient to do? Because I do a lot of respiratory, like COPD, asthma reviews, and I'm just thinking how
could that work?
For the cough, to get your cough points, because the GPs are always keen for that, obviously.
Of course. So yeah, absolutely. So really interesting. I'm going to send a case study out for asthma reviews. So we've got one practice in that has really done. It's really interesting when practices engage with this. Some of them just really hone their model to really improve it and get it to work really well. And they have actually replaced all of their asthma reviews with group clinics now. I mean, they do still offer obviously one-to-ones to some patients, but the sort of first contact is a group clinic, and they do both face-to-face and online. And how they do it is they're facilitators. They send out their ACT score beforehand. Patients fill it in. Their results board has the ACT score on it. They do some inhaler technique during the group clinic with people, watching each other doing it and learning from demonstrations and that kind of thing. And then the care plans are actually completed by the facilitator, because the facilitator has been there for the whole session and has heard everything that has gone on and has been taking notes, etc. And what that means, Lynn, is it saves double the amount of nurses' time, because you're not having to do the care plans afterwards for your asthma reviews. You've got all of your quaff sorted. And they actually say that has saved, that new way of documenting has saved as much time as the group clinic itself. So it definitely can be done. We design it all into the model. Somebody else asked a question about that. How do you do your quaff? Well, it's that results board that drives it, and you make sure that results board covers all of the quaff domains. So yeah, it's definitely possible, and I've made a note to send you a little case study of that.
Oh, thank you very much.
You're very welcome. Anybody else want to unmute? We're getting towards the end of the session, but if there's any thoughts. Oh, somebody's got their hand up. Whoever that is.
Got a hand up.
Caroline.
Hi.
Caroline.
Hi, I'm Caroline. I lead the heart failure specialist nurse team in Enfield in North London. And I just jumped on because it came up through our NCL GP nurses. So I feel I'm maybe not part of this group, but I thought I'd join anyway because I'm not a GPN or anything. But I'm really interested in to know what the GP nurses are doing, and I think there's some work going on with heart failure and GP nurses with the British Society of Heart Failure. So I joined halfway through, so I've only just joined, but I actually thought it was a group clinic. I thought it was the name group clinic was actually about different groups of nurses joining individual patients, so it was a multidisciplinary type thing. But actually, I'm really more interested that it's a group patient clinic. And I just wondered if anyone's doing it for heart failure. Do you know if anyone's doing a group? I mean, we do like support groups and that type of thing, but actually to see, has anyone done anything with heart failure patients?
They have indeed. Louise, do you want to say something about that, or would you like me to?
Yes, we did make a start from that in Greater Manchester. So we did it with the specialist heart failure nurses and the GPs and the consultant cardiologists. I think because heart failure is such a complex area, what the best use of a group clinic would be for a certain area of heart failure. So whether that is looking at early prevention and detection, or looking at how you monitor, your weight, wee and weigh, how you monitor for edema. So I think there are elements that we could do, and definitely when it comes to the management and titration of medicines, that's really important. What do our patients really understand about those combinations of medicines? Because that's often it's not included, is it, in the quality outcome framework. So a lot of the heart failure monitoring in general practice is monitoring, but not necessarily management. And as you said, Caroline, there is a good piece of work we're doing at the moment with the British Society of Heart Failure, but I'd be interested in picking it up with you outside of this meeting.
Great. I've put my my email in the group chat. Thank you.
Brilliant. There is, to be fair, Caroline, there is also some published evidence. So there's actually some trials, if you like, research, some research that's been done in heart failure as well. So there's definitely models there that you can do. I think the bottom line for you all to take away here is this group clinic model is very, very adaptable. You can use it basically for anything. You just need to design it to help you to do that. And as part of the sort of support package that we offer, we make sure that if you're doing something that is a bit unique and you're the first to look at it, we throw in some extra support for you to work with you and kind of scope it all out. How we can, one of the reasons we can really help with that is we can draw on lessons from other pathways that have a similar challenge in terms of the clinical conversation, and make sure that you learn from that. So I think we've come naturally to the end.